So let's see the morphology of Crohn's disease. So when the disease fully developed, we can see three characters. First, sharply delimited and typically transmural involvement of the bone by an inflammatory process with mucosal damage. This is the first, sharply delimited. And the second is granulomas formation. This granulomas is non-calcium granulomas in roughly half of the patient. And the third is the fusion with formation of fistula. The involved parts of Crohn's disease usually in these two parts, one is Crohn alone, 30%. Involve the small intestinal and the Crohn together, 40, and only small intestinal, also 30. This is the involved parts of Crohn. So here this picture shows us the gross view of Crohn's disease. This mucosa, submucosa, and here we can see this sharp ulceration. And this ulceration, perforation, then the fistulation and scarring of the subcellular tissue here. And for Crohn's disease, this is a normal area, and for here we can see the coagulate stone ulceration. This ulceration is deep. And microscopically, we can see here, this is the fistulation. Under high magnification, this granuloma, we can see these giant cells, but without calcium necrosis. So this is non-calciating granuloma in the Crohn's disease. So here, the Crohn's disease, we can see this fistula opening, connecting small bone and inner skin. This 1, 2, 3, with 3 fistula openings. So here is the clinical feature of Crohn's disease. The consequence of this Crohn's disease, the first is fistula formation. The fistula can be contacted with even the urinary bladder. This peria inner skin, just the picture show you. And the second is abdominal abscess. This is the perforation. Because of the perforation, the content of the intestinal into this cavity so causes peritonitis. And the third is intestinal structure and obstruction. So we have to do this surgical to remove this disease. So this is the first Crohn's disease. The character of morphology. And now let's see ulcerative colitis. So it's also high in the Western country. The incidence is 4 to 12 per 100,000 patients in the Great Britain, and this is the one of the Europe. First, the character is this disease is continuous involvement. We call this the pain colitis. And for severe cases, may cause toxic macron. It can destroy destruction of large parts of the mucosa. The mucosa will destroy or lose. At that time, the bowel contents impaired neural function, so will cause this paralytic ileus. Third, can cause this stasis, and cause this sepsis. This sepsis cause life-threatening sepsis, gangrene, perforation. And for long-standing ulcerative colitis, we say can cause this dysplasia and develop to the carcinoma. So here, morphology, we say we emphasize this continuous lesion, the whole colon involved. And the second, on the microscope, the ulceration is superficial. It's different with this Crohn's disease. This is deep, and here is superficial ulceration. And this area, this normal area, we call it is the schedule polypus. Now let's see from gross view. We can see here chronic inflammatory bowel disease. This is the ulcerative colitis. Here, this is the mucosa. Here you can see here, this area, we call it snake tract ulceration. The mucosa loose or destroyed. We can see this is muscular layer. Here is the mucosa remnants, 1, and 2 means muscular polyp, exposed to the content of intestinal. So this is a cut section of ulcerative colitis. We can see this is the mucosa remnant. It's same as the first picture. Here we can see the ulceration is superficial. It's limited, not so deep. So on the microscope, for this ulcerative colitis, we can see a diffuse predominant mononuclear inflammation without granuloma. This is the first difference between Crohn's disease and ulcerative colitis. Second, for ulcerative colitis, the ulceration is superficial, exposed muscular polyp. Third, we can see granulation tissue. The submucosa will fibrosis, and the mucosa will disarray and atrophy. So here is the histo character of ulcerative colitis. We can see this is mucosa involved by chronic inflammation. And here the glands destroyed, here the glands. And the third, the chronic lymphocytes hyperplasia called and form this follicle. For the submucosa and the deep level without inflammation. So this is ulcerative colitis. The inflammation, the ulceration, limited in the superficial. So here is the severe ulcerative colitis. We can see complete shedding of large parts of mucosa and submucosa. This area and this area, the mucosa and the submucosa disappear. Only left this area. So this severe ulcerative colitis often acute onset and may cause life-threatening bleeding because so large area of mucosa and submucosa destroyed, and also will cause acute toxic MAC clone because of the neural function imaged or impaired. So here, this picture shows us the dysplasia associated with lesion or mass. We say for ulcerative colitis, it is associated with carcinoma. And first, it will occur this dysplasia. Here, on the surface of the mucosa, we can see this area. And on the microscope, we can see in the ulcerative colitis, this dysplasia. Here you see this is a normal structure, architecture. This is the not normal, it's chronic inflammatory mucosa. And here we can see the dysplasia, this dark area. And here you can see the tumor. Why we say that this is tumor? Because it is not limited in the mucosa. It infiltrates to the submucosa. So we call it, this is malignant. So the clinic feature of ulcerative colitis is bloody mucoid diarrhea, low abdominal pain, fever, weight loss, and sometimes you can find bloody stools. The complication is carcinoma, and usually it's infiltrative type of carcinoma. And this carcinoma, the occur of this carcinoma is associated with the duration of ulcerative colitis and the anatomic existent. Usually when the disease less than 10 years and the disease limited on the left side, then it's, the associated is less or the minimal. And for the uncommon complication, you also can see this massive hemorrhage, diarrhea, and this toxic MAC clone. So here, this is the character of ulcerative colitis. There is no, or there are no scape lesion. It is continued lesion. There is no granuloma, but there is granulation tissue. Third, the mucosal ulcer is superficial ulcer, usually limited to submucosa. And fourth, there is less marrow thickening. The serosal surface is normal, is usually normal. And the fifth is high risk of carcinoma development. This is the character of ulcerative colitis. So now let's see the picture of diverticulum. So here is clone diverticulosis, many diverticulosis. Okay, then we finish the inflammation of intestinal. Now let's see the tumor in the small and large intestinal. First, benign polyp. This is the designation for each process, which is elevated above the original mucosa level. This is the polyp. So the polyp can be caused by edematous swelling, caused by infection, caused by hyperplasia, or the benign mesenchyma process of the submucosa. Some mesenchyma on the submucosa hyperlaration. And the last and important, adenoma. So this is the polyp, the model of polyp. We can see 1, 2, 3, 4, 5 are these different layers. And here is the polyp. This polyp is epithelial polyp, the epithelial cell proliferation. And here, this polyp is because of the submucosal polyp, submucosal hyperlaration, and then project to the lumen. And here is the polyp of the muscular layer. The last is polyp of epithelium and other mesenchyma structure. So first we will see this submucosal ball polyps, including lipoma, carcinoid. Lipoma, this benign tumor from fatty tissue. Here we can see in the submucosa the fatty cells proliferate, then you can see a mass toward the lumen. So this is one kind of polyp. This is from gross view. A polyp, and then we cut it, we find it's the lipoma. When we cut it, we can find this is a lipoma. And the second is the polyp of muscular layer, leiomyoma and the GIST. This is the polyp from GIST. This is gastrointestinal stromal tumor. So because of the mesenchyma in the muscular layer proliferation, and this tumor has, or these cells have the special immunostaining. CD117 is positive. CD34 is positive. This is the marker of this tumor. And for the smooth muscle, the marker for smooth muscle, actin desmin is negative. So we can see this is a spindle cell carcinoma, a spindle cell tumor. So immunostaining, the GIST is CD117 and CD34 positive. This is positive. It is distinguished with leiomyoma and schwannoma. Here you can see actin desmin positive. This brown staining. Here is the CD117 and 34 positive. So this is the tumor, spindle cell tumor. These three tumor, the tumor cells, all of the tumor cells are spindle cells. So this immunostaining can help us to distinguish, because from morphology they are all spindle cells. But from the immunostaining we can see this is the tumor, this CD117 34 positive. And here actin and desmin for tumor is negative, but for the smooth muscle is positive. This is the positive control. And here for S100, the tumor also negative. So this is the GIST. So for this tumor, there's no difference between female and male. Most occur in the stomach. Some occur in the duodenal. It can be malignant. 1 to 3rd metastasis. So this is malignant. It is associated, malignant or the benign is associated with the size of this tumor. When it is less than 5 centimeter, mostly benign. But when more than 10 centimeter, frequently malignant. This is the one part to help you distinguish malignant or benign. Another part is the under microscope to see the mitosis, the number of mitosis. Under 50 hyper magnification, when the mitosis less than 5, we say it's benign. 5 to 25, then it's low-grade malignant. More than 25 is high-grade malignant. So for this GIST. And for this malignant GIST, we have no efficiency therapy. But now we find a target therapy for this kind of patient. Because this kind of tumor, we find a somatic mutation in the c-KIT gene. This c-KIT gene, just CD117. And it's encoded this tyrosine kinase receptor. This tumor, this malignant, has this gene mutation. And we find this target drug, this imatinib mesylate. This drug can inhibit this tyrosine kinase. So this is efficiency to this imatinib is efficiency to the malignant GIST.